Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by High Tech Answers and Healthcare Now Radio, part of the Answers Media Network, and is sponsored by the law offices of Myrick O'Connell. Now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Doug Dietzman, Executive Director of Great Lakes Health Connect. Welcome, Doug.
Thank you for having me. Glad to be here.
Yeah, no, it's great to meet you. I've certainly heard a lot of great things about Great Lakes Health Connect and have interacted with one of your colleagues, Brian Mack, a lot on Twitter before.
Great. Yeah, he's a good man. Glad to have him on our team.
So if you could you just give everyone a little bit of a background about who you are and what you do at Great Lakes?
Sure. I'm Executive Director for Great Lakes Health Connect. Been with the organization since its founding, although Great Lakes Health Connect itself in 2014 to a merger of two HIEs, and I was part of one of the predecessor organizations going back to 2009 at its origin. So been with the organization now for a number of years.
All right, so, and I think actually you were going to go to my next question a little bit, which is, can you give us a little bit of a background about Great Lakes Health Connect and, kind of where it fits within the HIE landscape?
Yeah, and I'll start back with the predecessor organization, which was Michigan Health Connect at the time that I was part of. But that really formed initially when competing healthcare organizations came together and said, this HIE train is coming at us. And we're either going to agree to not compete on this clinical data exchange and do the right thing for the folks in our community, or somebody else is going to do something for us. So they did. They agreed to not compete that way, came together. There's 3 health systems at the time. Eventually, through 2009, others came to the table. There was 7 different organizations in Michigan, and they put money in a pot and asked me to who had been facilitating their conversation, to see if there was a business model and what might come of this HIE thing. So in March of 2010, that organization was created with just me and some money and an idea, and then from that point forward, just continued to see what problems needed to be solved and continue to grow it from that point forward.
So this was something driven by the private industry, then, it sounds like.
Yeah, absolutely. Great Lakes Health Connect and through its predecessor organizations has not been funded by federal or state grant monies. None of those dollars really came down to us. It's all been based on private funding. Kind of had the thought from the very beginning that if we can't provide services that the provider community isn't willing to pay for, if we're not solving a problem that justifies kind of giving us money for our existence, then we shouldn't exist. So it's forced us to be really tactical without those big millions of dollars of kind of sitting back there to have to spend. We've had to be very tactical about what we do, how we spend our dollars, and what problems we do solve.
Yeah, this is very interesting. So, if you don't mind my asking, so how does the kind of funds flow work? Are you expected to generate your own funding, or do the organizations commit to kind of like a membership fee or something similar?
Yeah, we have tiered a little bit. So we do have a membership fee that we charge. That's the smaller part of things, but kind of coming in the door, most organizations pay something. And then we really set up a menu based on the solutions and services that we provide. So depending on what you want from us, then you pay an ongoing solution fee associated with it. We're not locked in. None of our customers are locked in for any long term. So if we stop adding value or those solutions aren't valuable to them anymore, they can stop them anytime. So again, it continues to put the onus on us to continue to do a good job in how we operate all of it. Are the hospitals, just because they're the larger organizations in the state. We do offer most of our services to the independent physician community at no cost. So we send their immunizations to the state. We give them access to the longitudinal health record, results delivery into their EMR, our referral platform, all of those things we provide to them and don't charge them anything just because they're already up to their eyeballs in calls trying to figure out how to get the EMR
Right. So it sounds like you have a very broad scope of services. So kind of what are your challenges for operating? Because obviously one that would at least pop top of mind for me is I'm guessing working with a whole host of different electronic medical record systems, and oftentimes that's heard as a large issue whenever you're trying to deal with getting information flows across different practices. So what kind of what are your biggest challenges?
Yeah, I think that's certainly one, but to me that's the expected one. I mean, the large reason for our existence is the fact that there are many systems, even physicians without systems, that still need to be plugged into this ecosystem in some way. But if they were all the same system, or if all the systems just universally talk to each other in some magical way, then there would be less need for those of us in the middle that are helping to broker the conversation. So multiple EMRs is a challenge, but it's part of what we expect. It's part of what we do. I think the bigger challenge for us just in general is that this industry is changing so fast. We've thrown the financing of healthcare up in the air, moving to value-based payment. We've thrown the clinical practice of medicine and how we organize clinically with care teams, now extending beyond the four walls of our practice to put these accountable organizations together. So we've thrown both of those things up in the air, but then have said, hey, let's throw some technology in there and solve all those problems and just make it work great. That's a challenge because we're great as an industry at applying technology to well-defined business. When business is kind of all jumbled up, it's harder to understand exactly how to make the technology apply appropriately. So that's one of our bigger challenges.
Right. Yeah. No. I think as you said, it's very tough to create or modify a solution when you're working within a continually moving target.
Exactly. Yeah, and there are lots of experimentation going on. So there's not even really one target. There's all these different things that CMS is trying, that the states are trying through the Medicaid programs, that the individual health systems are trying in at different varying places of evolution and technology. So we have to meet everybody kind of where they are along that continuum and apply our services and kind of our capabilities to wherever they happen to be to help them make the next step along the journey. So it's a challenge, but from my standpoint, that's what makes it fun. Nothing's the same every day.
Yeah. No. The saying is variety is the spice of life, right?
Yeah. Right.
So as you're talking about working with organizations going across the spectrum, I think you mentioned you've got some that don't even really have electronic systems. So I'm guessing that means they're still primarily on paper to likely some very sophisticated organizations in terms of where they stand on adoption of technological solutions. Which side do you find more challenging to work with? Do you find it would be the ones who are, let's call it the early stages of adoption, or the ones who are further along?
Yeah, it's an interesting question. They're a little different. I think the challenge with those that are more sophisticated, have the larger systems, is there can be the belief that we've got it all. If you have Epic or you have Cerner, if you listen to some of the vendors speak, you don't need anything else. You're self-contained and you have everything you need. Plus, if you're larger, you have more resources, both financially and from a staffing perspective, to kind of deal with things. When you go on the other end of the spectrum with folks who don't have technology, typically they're just scrambling day by day to get by. So their capacity to inject new things into the workflow or financially to try and invest in anything new is really, really limited. And so how we engage them has to be different. But if we think about the community as being physical, behavioral, and social service organizations all in the same ecosystem across the community that patients are moving through, you can't leave any of them out. And so that has become where we've had to engage kind of each sector wherever they happen to be again and figure out kind of what their challenges are, what the story needs to be to tie them in, and then figure out how we get everybody to play together in the same sandbox.
Right. Yeah. No. It's I definitely agree. It can always be challenging when you're dealing with a variety of players and a variety of viewpoints of figuring out how to align all those. So I guess kind of from that perspective, as you've worked with those different viewpoints, are there kind of any best practices that you feel like you've been able to develop, or other other tips or items that you think are generally applicable to HIEs across the board?
Well, I think short answer is no, relative to is there one solution or one approach that just works for everybody. Even in the hospital setting, if we stick there, the 2,000 bed facility is different than the 25 bed critical access hospital and kind of what they're trying to do and who they serve. The urban center is different than the one who's more in a suburban spot. So I think the one thing that is common, though, is really the mindset of going in and listening first. Covey had that, one of his principles is seek first to understand, then be understood. So I think in our past, as we've gone out and said, hey, we've got a cool thing, don't you want it? The answer has always been no. Nobody wants HIE. Nobody wants what we do. But I think as we listen to what they're trying to accomplish strategically and listen to the problems they're having, connecting across the community, getting the data they need, and say, if we could help you solve that problem, is that interesting to you? Then it doesn't matter who we're walking into, who we're talking to. That approach has tended to help us find the right places where we can be of value.
Right. That's an interesting statement that you said. A lot of people say to you that they don't want an HIE. Why do you think that they say that to you?
Well, because they're just, again, overwhelmed with EMRs, with the meaningful use, macro MIPS coming, quality measurement. How are we going to do that? There's new alignments in the industry, partnerships that are coming in. I mean, they're just absolutely overwhelmed with the business side of it, let alone just managing their clinical operation, what they went to school to do, and taking care of people. So I think when we come in, just almost like any other vendor, and say, hey, would you like to do something new? No. Even if the new is better, it requires change, and change is always hard for folks, particularly if you're scrambling. I'll take the inefficiency that I know because I know how to plow through it, rather than having to step back and hope that something else works better. So, our referrals is one example. We've walked into offices and said, would you like a referral tool? And no, they don't want a referral tool. But again, as we had the conversation, as you're transitioning patients, who do you have the most struggle getting information back from? Who do you struggle getting patients into in an efficient way? And as they start to tell all their war stories, that's where then we can say, well, if we help do that better, would that be okay? And that resonates much more strongly. And even then, and I'll stop, but even then, change is hard. And getting folks, even if they see it with everything else that's going on, getting folks to kind of accept something new and bake it into the workflow is just a challenging thing.
Yeah, no, I definitely agree that as you were saying, change is definitely hard. And, even though as you're saying, you're explaining how it can be beneficial and help improve efficiencies and help improve the workflow, I guess conceptually hearing that and then seeing how it works in practice are obviously two completely different things. But as it sounds like obviously as you were saying earlier that you've been, building this network for I think roughly 7 years now. As you said, two separate groups and now one combined one. Are you finding any kind of change in attitude or receptivity to that type of change?
Well, I think, yeah, one thing that's changed a lot, back when we got started, it was kind of a theory. There was maybe meaningful use pushing certain things, but the business model was still the pretty typical fee-for-service model. I think as things have evolved over the 7 years, and we're seeing a lot more push in this accountable care space, and it's no longer that theory that folks were figuring out, but folks are really starting to get their arms around what it means to kind of manage populations and understand the pieces and parts of that. I think the reality that's becoming clear to them is if I'm responsible and at risk for a population, I no longer just care about what happens to them in the four walls of my facility. I have to be understanding and care about what happens when they're out there somewhere, because what happens out there can affect my reimbursement, it can affect my cost structures, and that sort of thing. And that's where the HIE its longitudinal health record just comes into play beautifully there. So I think the recognition of how that fits and where we fit into the flow is different today than it was 7 years ago when we got started, and we're just talking about, immunization transactions or results delivery.
Yeah, no, I think that point about needing a longitudinal record access, and as you said, thinking about it beyond the four walls of a particular practice is very important because as you said, as we're moving into an alternative payment world, you have to be able to get access to the data to be able to understand where all the cost is and where all the impact could be arising.
Yeah, and it's not either just a reporting or analytic question, which I think sometimes it can flow to. If all we're doing is reporting how well we do at the end of the year, but we don't have the capabilities on a day-by-day basis to figure out how we impact those measures, then we're just hoping when we get there that we're doing things better. So I think our longitudinal health record at the point of care, the ability to help in the transitions and make sure that folks are getting to their appointments and that things are being followed up with the right way, and the movement of data otherwise through notifications and other types of alerting, all of that comes together on a day-by-day basis, which are the things we provide across different healthcare stakeholders that drive when you get to the end of the year and now you want to do your reporting that you've actually changed and moved the dial.
Right. And I want to kind of go back a step or two to something you were mentioning, which is obviously saying that a few years ago it felt like a lot of things were being driven or influenced by meaningful use. So I want to kind of break that into two pieces. The first one being, as you said, your organization having been created by private industry, did you feel you had a little bit more freedom because you weren't relying upon any type of state or government funding to operate?
Certainly did. I mean, I think governance was different. A lot of the playbook back in the day was you had to have one of everybody sitting around the table. It became, very governance heavy, and getting agreement on specifically what you needed to do was a challenge for most. I think being private and still having the community interest at heart, but having a tighter kind of governance structure and a more focused, being more focused on the specific problems allowed us to be more nimble in what we attacked. And some of the early use cases were basic blocking and tackling. We didn't build an MPI right away. We didn't build a provider directory right away, because most of the hospitals that we were working with at the time said, we've got 50 physician offices knocking on our door wanting an EMR interface across these 25 different EMRs, and we don't want to have to learn them all. We don't have the staff to do it. So we said, well, you give us all your results. We'll turn around and we'll deal with all the complexity of how that data gets out to wherever it kind of needs to go. But what it did in those early days is it got the data flowing. Now the data was flowing. Now we could start talking about other things we could do with it to add additional value. So it wasn't sexy, but it, I think, was an important building block that others may not have focused on initially because they were running after other things that the grant dollars said they needed to do.
Right. So, even though you had that freedom, did you still feel regulatory pressure?
We didn't feel it directly, but we felt it indirectly through our participants. So to the extent that they were feeling pressure to have to do certain things or had deadlines that they had to meet, we felt those indirectly coming at us because we had to help them meet those requirements.
Right. And so, I think we're kind of ending up with the conversation going more to, health information exchanges or HIEs from a general perspective. So thinking about the broader realm of HIEs and, across the country, what do you see as the biggest challenges? Do you think, we could go in a direction where there would or should be a national HIE to connect the different ones that may exist in different states?
Well, I think, so on that last point, I think we are going to need and are developing ways to send some basic transaction sets across the country. But I think that the things that drive healthcare are so local, and it's not primarily a technology problem. It's a workflow problem in how the physical, behavioral, and social interact within communities, how we find what the resources are and how we get people into those resources. So I think just having a national network doesn't solve kind of that local problem. We're always going to have a need there. Our cost and quality issues in the country are not driven by the fact that we can't send something to Arizona seamlessly. And if we built that so that we could send data to Arizona seamlessly, it wouldn't solve the cost and quality problems by itself. So that national moving data around isn't the fundamental reason that we're needing to really focus on this cost quality question. So I think if we focus on those, what's driving the cost quality question, and use technology and HIE as a means to enable and support how we go after those, we'll be in a better spot than just focused on, can we figure out a way to create a national network just to have a national network and not have it maybe turn out the way we hoped it would relative to solving problems.
Right. So maybe to push you a little bit on the cost and quality piece of it, because I definitely agree with you that, you know, just having data flow for the sake of having data flow doesn't solve any problems. You know, what do you see as solutions or tools that could help with the cost and quality issues?
Well, all of the movement toward this population health incentives, everything fundamentally boils down to incentives. We as individuals are incented based on our life to eat the cheeseburger or not, to exercise or not, to take care of ourselves or not. And I think we've seen in our healthcare system that when providers are incented to perform services, they perform those services and they do them really well. But if they're not incented in any way to kind of watch out for me holistically, then they just don't, not because they're evil, but just because incentives drive, kind of our behavior. So I think that seeing where the trajectory has gone in the country, that movement with the payment models to providing oversight to populations, to looking at that overall health, having to care about that full org, and then even through some of the products that patients have with the high deductible plans and some of those things that actually force us to pay money out of our pocket to do things or not. If we're sicker and we have to go to the doc a lot, that's going to cost us money. It's helping with the incentives. Those things, I think, fundamentally will drive down a lot of the cost quality sort of issue. And then the question is, what technology, what do we need to do from an exchange standpoint to support those efforts to manage those populations? And if we get that marriage right, then I think we'll have opportunity to have some significant impacts in our community.
Right. So I definitely agree that the incentive seems to, be a common driver for human behavior. I feel like I hear that statement quite a bit. In terms of how, also going back to a statement that you said of, a lot of these issues are local and in the community where, for the most part, your care is being delivered. What do you think about calls of having, really going down to the lowest level, you could say, from one perspective of, each individual is the one creating basically an HIE of one, so they're making sure that their entire record is all in one place. Kind of what are your thoughts on that concept?
Broke up a little bit in that we've got a bunch of local ones that maybe aren't connected, and what does that mean?
Well, no, actually, what happened, there's some discussion of, that the patient themselves should be the central repository for all their own information, be able to help spread that out. So, which is really, I guess, kind of like an HIE of one. So I just want to get your thoughts on that concept.
Yeah, well, so I don't believe that patients want to be in that role. I think that we've seen with some of the efforts of Google and Microsoft or others that have had kind of generally accepted patient portals that they don't get the full large populations of individuals wanting to manage that. As a parent, and I tell some of my own stories of healthcare in our family, I don't want to be responsible for carrying a paper binder, and an electronic binder isn't a whole lot better to me from provider to provider to provider to make sure that they are informed of what they need to know to best take care of me. I do it because I have to, or I do it for my kids because I have to. But I don't think most people want that. They want to show up and they want to know that the healthcare community has shared the information necessary through that transition to take care of them, that it just works. So I do think that we will have certain populations, those with chronic conditions or whatever, that want to manage their own personal health record, and that they want to dictate who can see what and all that sort of thing. Challenging on a wide scale to figure out how to administer that. But I think the big population, if we're going to go after everybody, the vast majority of folks I don't think want that. And as an industry, we should be figuring out how do we make sure the right data gets to the right spot without requiring the patient to have to be the broker.
Yeah, no, I definitely agree with you there. It's, we all expect that the information will be in the hands of the individuals who need it. We don't want to have to worry about it. But I think it also goes back to, as you were saying, some people will want it, and that's just there is not one solution that will fit every situation.
Right, and some folks have to keep track of things on a more everyday weights and different things that are going on with them, and they have to kind of for their health. So I think there will be folks that want to manage that. But again, I think the big driver of the cost and quality issue in our country is not solved by getting the 25-year-old to monitor things on their mobile phone. That's not where the cost and quality issues are. It's cool, and it can be helpful, but I think sometimes that can be a little bit of a distraction from that sweet spot where we're really struggling with figuring out how to manage chronic disease at the end stage of life, or some of those places where we can really have a much larger impact.
Right. So as we're starting to very quickly already run out of time, I just want to get your final thoughts on one question, ask you to kind of look into a crystal ball a little bit, but, where do you think HIEs will be going over the next few years, understanding that there is going to be, or expected to be, a lot of volatility still within the healthcare industry?
Well, I think there's one of the questions out there is, are they going to be government run, kind of owned? Are they going to be personal owned? As you said, there was an article that just came out in the last couple of days on those two. Really didn't address whether there's room for private organizations, which I think is really the one. The patients don't want to. The governments won't be efficient at it. There's not going to be federal or state funds, I think, to invest the necessary amounts and have the trust to kind of do it. So I think it's going to be on private organizations that are trusted who are going to do it. We have administrative clearinghouses that continue to exist for claims that are about as standardized as you can get over the years. So I can see in 5 years having more regional, those that have figured it out, kind of extending beyond state lines, having more regional networks that form. But I think fundamentally, HIEs won't exist or won't be most successful by being wide geographically and thin from a transaction standpoint, kind of like the administrative clearinghouses. I think that what you're going to see for those of us in the future, and where I'm driving things, is I think we have to maybe get a little bit wider, extend our reach, and do the right thing to try and make the network as large as we can. But it's going to have to drive deeper. We can't bounce across the surface and just do some transactions. Those things are going to commoditize. If we're going to make a difference and we're going to really use this data asset that we're creating, we're going to have to go much deeper into the workflow and into solving community problems. For example, super utilizers. No one organization knows who's bouncing across all 3 emergency rooms within a particular community. We do. So how do we then take that data and do something for that population we haven't had visibility to before, to actually change the way care is delivered for those folks and change the cost quality focus for the community? And I think that's really the future where we need to go, is to dive deep and to really figure out how we use this asset that we have in a way that actually turns the dial.
Right. No, that is certainly a lot of food for thought. And as I alluded to, believe it or not, we're already out of time. So I want to thank my guest, Doug Dietzman, for a great conversation today.
Thanks, Matt. Appreciate it.
Yeah, no, and thank you to everyone for listening. Keep the dialogue going and connect with me on Twitter at #HCDEJURB. I'm Matt Fisher. Until next time.